Good morning, everyone. I would like to thank Rita Stearns, the volunteers and organizers of the CARES conference for putting together this wonderful event. Today I'm going to talk to you about cataracts and the glaucoma patient. Let's talk about cataracts briefly. I'm sure most of you have heard of cataracts, are familiar with them, or have probably even had cataract surgery. They come in three varieties. They are nuclear, cortical, and posterior subcapsular, and essentially all of them imply some degree of opacification or haziness of the natural lens within the eye. The lens, of course, is part of the optical system of the eye that focuses the light. They can be acquired. The most common reason for acquiring cataracts is simply by aging. In fact, cataracts are found in over 70% of individuals over 70 years of age. So in some sense, it's just a normal part of life. Other reasons for developing cataracts are trauma, certain illnesses such as diabetes, lifestyle choices or habits such as smoking, and perhaps poor diet can also hasten the development of cataracts at a younger age. Medications can also cause cataracts. Most importantly, chronic steroid use can lead to cataracts. Cataracts can also be congenital and are found in 1 in 2,000 births. Modern cataract surgery is called phacoemulsification, and here's a brief video showing this. We make incisions in the cornea. A jelly is placed within the eye to create a space between the lens, the cataract, and the cornea. The opening of the cataract, this is called the lens capsule. An opening is made in this lens capsule so that the cataract can be accessed and can be then later removed. Now this step is important because the capsule is actually left in place. The rest of the capsule is left in place. The artificial lens will actually go into this capsule in the end. So in some sense, think of cataract surgery as the swapping of a hazy lens for a clear lens. In this step, the cataract is freed from this lens capsule with fluid. And now an ultrasound probe is introduced into the eye, and this ultrasound probe liquefies and removes the cataract. And here we're going to see the ultrasound probe removing the cataract in several steps. Before the advent of modern cataract surgery techniques, cataract surgery was more complicated and difficult. Today, cataract surgery is one of the most commonly performed surgeries and certainly one of the most successful. Here's the capsular bag that I spoke about. Some remaining lens material is vacuumed away, and the capsular bag is left empty for the artificial lens to be placed. The capsular bag is supported within the eye by a series of what's called zonules, or support struts. Those can't be seen in this video. Here is the artificial lens going into the space where the cataract had been vacated. The lens fits right into that place. The incisions that were made self-seal. Now let's talk about cataracts and glaucoma, and I would like to touch on three general topics. Now this is obviously a large discussion. Cataracts can be a talk that goes on for hours, but I would like to focus on three areas that I think are of interest to the glaucoma patient. They are glaucoma drops and cataracts, glaucoma surgery and cataracts, and finally the type of glaucoma and cataracts. So the question first is whether glaucoma drops cause cataracts, and I've been asked this by my patients in the office, and I think it's a good question. In fact, there is a higher incidence of cataracts in patients who are on glaucoma drops, and this is found in several large studies. One of these studies is the Barbados Eye Study. Obviously, this was performed in Barbados, and this was sort of a population survey of people with glaucoma, finding higher incidence of cataracts in folks who were taking drops. The early Manifest Glaucoma trial was a trial of Northern Europeans. Essentially, in this trial, they took patients who had early glaucoma, they treated them with drops in one group, and they observed the other group. The idea of this was to see whether lowering the intraocular pressure would reduce the progression of glaucoma. Anyway, in that study, the folks who were on drops were seen to have cataracts a bit more than the folks who were not on drops. However, The benefit of being on a drops was proven in that study, as the folks who had lower pressure had a lowered progression of their glaucoma. In other words, their vision from glaucoma did not get worse, as much as the folks who were not being treated for their higher pressure. So those two studies found higher incidence of cataracts on folks on drops, and there was also higher incidence of cataract surgery in people with ocular hypertension who were taking glaucoma drops, and this was found in the ocular hypertension treatment trial. So these are three major studies that found higher incidence of cataracts in folks on drops. However, all these studies have some limitations, and that is that the study was not designed to really answer the question as to whether drops for glaucoma cause cataracts. The studies were designed to answer other questions. So there could be other factors at play here to describe why some folks are developing cataracts. For instance, perhaps there are other things within the drops themselves. Perhaps it's not the medicine from the drops at all. Perhaps it is the preservative in the drops. The answer here is that we really don't know for sure whether the drops are causing cataracts, and we don't know for sure which drop is better or worse than the other. For the time being, I think it is fair to say that the drops may cause cataracts. It is also fair to say that the benefits of the drops in the vast majority of patients are far outweighed by the possible risk of having cataracts develop sooner than they otherwise would have. Does glaucoma surgery cause cataracts? Well, several large studies have looked at this question as well, and have also found that perhaps glaucoma surgery may hasten the development of cataracts. For instance, the Advanced Glaucoma Intervention Study found that the patients treated with trabeculectomy had an increased risk of developing a cataract. The risk was increased by 78%. Another study was called the Collaborative Initial Glaucoma Treatment Study, or CIGITS. In this group, they took patients and they divided them into two groups. One group had surgery to manage their glaucoma, and the other group had medicines to manage their glaucoma. The rate of cataract progression was 3 times higher in the surgical group. So as to the question as to whether glaucoma surgery causes cataracts, again, the answer here seems to be a qualified yes. However, it is important to note that certain complications or difficulties during surgery may lead to cataracts. For instance, a flat or shallow anterior chamber, or increased inflammation in the postoperative period. These studies did not specifically look at that issue. So perhaps so one may answer, yes, complicated glaucoma surgery certainly will lead to a hastened rate of cataract development. However, perhaps simple and uncomplicated glaucoma surgery, I would say the question is still somewhat up in the air. Now let's talk about the type of glaucoma and its impact on cataracts and implications. Well, in general, there are two main types of glaucoma, and I'm sure many of you have heard this before. There is angle closure glaucoma, and there is open angle glaucoma. And within open angle glaucomas, I'm going to pay a special mention to pseudoexfoliation syndrome and pseudoexfoliation glaucoma. So let's start with angle closure glaucoma. Angle closure glaucoma represents 1/3 of the total glaucoma cases. So there are about 20 million people worldwide with angle closure glaucoma. Of those people with angle closure glaucoma, the majority of them are in East Asia. And of the folks with angle closure glaucoma, a slightly greater percentage are women. The problem here is something called an occludable angle. This is found in 4% of people of European descent, approximately, and about 10% are higher in individuals of East Asian descent. And here's a cartoon that I hope helps illustrate what an occludable angle is. You see, the aqueous fluid is made in the back of the eye. It's made by a gland called the ciliary body. The fluid is produced by this gland. It flows around the lens, it flows around the pupil, and eventually is drained through the natural drainage system, which is called the trabecular meshwork. Okay? Now, in this cartoon, you can see that the fluid cannot have access to the trabecular meshwork. The problem here is that the peripheral iris covers the drain. This is an occludable angle. If this condition is left untreated, it can lead to glaucoma because the drain can become less functional. Or there could be an acute rise in the pressure as the drain is completely closed off. That is called an acute angle closure glaucoma attack. Those are rare, but are very serious. So the primary treatment for angle closure glaucoma is a laser iridotomy. In a laser iridotomy, a small hole is made in the peripheral iris with a laser. You can see here a slit lamp photo of an individual who has had a laser iridotomy. Now, the laser iridotomy is tiny. It can't be seen really with the naked eye, but really only on a clinical exam in the slit lamp. And here's a cartoon illustrating why a laser iridotomy is helpful. The fluid doesn't have to take that circuitous route around the lens and around the pupil and down the drain, but rather goes right through that little hole in the iris. What this does is it increases the size and depth of the anterior chamber. And in the majority of people treated with a laser iridotomy, it opens the drainage system. However, medicines may still be needed in individuals with angle closure glaucoma. And in some folks, they need glaucoma surgery, such as a trabeculectomy or a tube shunt. However, glaucoma surgery is more risky in individuals with angle closure glaucoma. In particular, individuals with angle closure glaucoma are more prone to a flat or shallow anterior chamber during or after surgery. Lately, cataract surgery has been investigated in its role with angle closure glaucoma. We know that the lens plays a role in angle closure glaucoma. In fact, some studies have found, particularly in the Asian population, that the lens in an individual with angle closure glaucoma is fatter, thicker, and it just crowds up the anterior chamber, takes up space. There was a study done in Hong Kong, which was a small study. In this study, they took 21 patients with angle closure glaucoma. These are patients with glaucoma, with nerve damage, who are on drops. And in those patients, they performed cataract surgery. Now, this is important because they performed cataract surgery, but not all these patients, these individuals, had cataracts that were that visually significant. But nonetheless, cataract surgery was performed. The idea here being that taking out the cataract may help open up the drain and may benefit these people. At least that was the idea. Now, this was in general in this study. They found that the intraocular pressure, that's IOP, the intraocular pressure and the number of glaucoma medications was decreased after the surgery. And I think this is an important study because there is more studies being designed after in which they're trying to answer just this question. And I think in the future we may see more individuals with angle closure glaucoma having earlier cataract surgery. There does seem to be a benefit here in helping open up that drain, provide access to the trabecular meshwork. And it seems that in many folks with angle closure glaucoma, it can be beneficial. So we will see as more studies come out about this important question. Now, in some individuals, cataract surgery and trabeculectomy are combined. This is basically a case-by-case decision based on the presentation of the patient in the office, how uncontrolled the intraocular pressure is, how many drops they're on, how damaged the nerve is, how damaged the visual field is, etc. There are many things that go into the decision to provide glaucoma surgery. Providing cataract surgery and glaucoma surgery at the same time may have some advantages in an individual with angle closure glaucoma. It may achieve a lower intraocular pressure postoperatively, and it may also help prevent postoperative intraocular pressure spikes. Intraocular pressure spikes can be seen in folks with glaucoma who have cataract surgery, and doing the trabeculectomy or other glaucoma surgery at the same time may help prevent these. However, the downside is that combining cataract surgery and a trabeculectomy or glaucoma procedure may lead to more postoperative complications. Now let's talk about open-angle glaucoma. Well, some interesting studies have come out in which we have found that the intraocular pressure after cataract surgery alone in folks with glaucoma who are on drops, we found that the intraocular pressure is lowered by about 1 or 2 millimeters of mercury. However, unfortunately, the pressure returns to baseline over time. So my statement above that cataract surgery alone is not sufficient treatment for patients with glaucoma, that statement stands. Sometimes cataract surgery and trabeculectomy or other glaucoma surgeries are combined, just like in angle closure glaucoma. And just like in angle closure glaucoma, there are many factors that go into this decision. There are, as I spoke above, advantages of performing both surgeries, both in lowering the intraocular pressure and getting the patient hopefully off many or all of their glaucoma drops. There are the same disadvantages would apply, that the postoperative complication rate is probably higher in individuals that have both cataract and a glaucoma procedure. Finally, though, there is one advantage I would like to talk about, and that is this. Performing cataract surgery in a patient who has a pre-existing bleb can risk having the pressure rise after the cataract surgery. We think this is due to postoperative inflammation and scarring that happens within the bleb that had been functioning before. So thus, there's now some individuals and glaucomists and surgeons who are thinking that it might be better just to go ahead and take care of both surgeries at once, the cataract and the trabeculectomy. Like many things in glaucoma, the jury is still out on this one. And generally, I would say it is safer to say this is a real case-by-case decision on whether a patient needs glaucoma surgery at the time of cataract surgery. I would like to talk about pseudoexfoliation syndrome because it does have some impact on cataract surgery, and pseudoexfoliation syndrome is a cause for glaucoma. Pseudoexfoliation syndrome affects about 60 million people worldwide. This is basically a condition in which you have this fibrillar or white sort of flaky material on the anterior lens capsule. You also may see clinically on examination your glaucoma specialist may see pigment deposition in the trabecular meshwork. Now, about 40% of individuals who have been diagnosed with pseudoexfoliation syndrome will develop glaucoma about 15 years after the pseudoexfoliation syndrome is first discovered. So this is a major risk factor for developing glaucoma. Pseudoexfoliation syndrome is found more commonly in certain populations, for instance in Scandinavians or in Russians, but it is distributed worldwide. Some studies have found problems with individuals with pseudoexfoliation syndrome or pseudoexfoliative glaucoma. For instance, in the EMGT study, which I mentioned before, individuals with pseudoexfoliation glaucoma were more likely to have glaucoma progression than individuals with simple open-angle glaucoma. Individuals with pseudoexfoliation syndrome are also more likely to develop cataracts. With pseudoexfoliation syndrome, or XFS, the surgery may be more difficult. In fact, prior studies found a 10 times higher complication rate in an individual with a pseudoexfoliation cataract than one without. However, today, with modern surgical techniques, the complication rate is actually found to be similar to that of sort of routine cataracts. Some of the problems, though, that we see is something called zonular laxity, where the lens support or the cataract support within the eye is poor. This can lead to lens dislocation, either at the time of surgery or delayed postoperative artificial lens dislocation, which is seen here. Now, complications during surgery can be prevented by careful preoperative evaluation. Not always prevented, but it can be. For instance, one can see a shallow or a very deep anterior chamber. All these things connotate a loose lens. One may see a small pupil indicating poor dilation, and this can make the surgery more difficult. The top cartoon here illustrates some of the techniques one may need to use during cataract surgery for an individual with pseudoexfoliation syndrome, certain aids that you use at the time of surgery, and these are called capsular bag hooks. So in an individual with a loose lens, a lens that is threatening to fall into the back of the eye, these capsular bag hooks can help hold the lens up so that the surgery can be performed. In conclusion, cataracts may be more common in individuals with glaucoma for the reasons I stated above, the drops or having surgery. Okay? Cataract surgery may benefit individuals with angle closure glaucoma, so earlier cataract surgery may be beneficial in those folks. Finally, most individuals with pseudoexfoliation glaucoma can have successful cataract surgery, but it's important that a good preoperative evaluation is performed. I would like to thank everyone for your attention today. I'm sorry I could not be here in person, but I'm sure you will enjoy the rest of this conference.